Okay. Well, welcome back. We're looking forward to some dermatology now this afternoon, starting out with Dr. Alexandra Charrow, who's assistant professor of dermatology at Harvard Medical School. She is trained in internal medicine and dermatology, is the director of the hidradenitis suppurativa and neutrophilic dermatosis clinic at Brigham and Women's Hospital. And she's here to give us an awesome talk on difficult dermatology cases for the hospitalist. Go ahead, Dr. Charrow.
Thank you so much, Dr. DeFrancisco. So today we're going to be talking about updates in hospital medicine, specifically emergency rashes, which hopefully will be relevant to everybody here today. And this is my background and a little bit about myself. I direct the hidradenitis clinic at the Brigham, and these are my disclosures. Today, our goals are going to be twofold. First, we're going to be covering and trying to develop diagnosis and differential tools to treat the most common and worrisome rashes in dermatology. And then my hope is to arm you with some tools and instances when we should be elevating care or thinking about transferring patients. We'll start with cases. Today we'll be covering 4 cases. Case 1 is a 54-year-old woman with past medical history of a knee replacement 1 month ago who's presenting with a rash. You can see here this is one example of the kind of rash that she presents with, and another example of the rash that she presents with here. And I would want you to direct your attention to how to describe and think about these two very similar rashes, which is that they are confluent, in other words, a collection of papules and sometimes maybe macules that are coalescing into these larger plaques. Almost all rashes have some raised component to them. So instead of saying maculopapular, another more cumbersome way to say it would be to say papuloplacular, because really that's what's represented here. And you can see that there are areas of sparing, so areas where the skin looks relatively typical or normal, and then areas here where the confluent rash has taken over. The other thing I would focus on is that this is occurring on the trunk itself. When we're assessing any patient who has a rash, we try to focus on 3 basic sections. First is the history, and with respect to the history, we care about medical history, infection history, and immunologic status, no matter what the rash is. Second is symptoms and signs, specifically thinking about systemic symptoms, fevers, lymphadenopathy, skin pain versus itch, and then mucosal involvement. And then we, generally speaking, care about CBC with ZIF, LFTs, and BMP. It is always the same for any rash that I'm going to see. I'm always going to be asking the same set of questions and doing the same kind of exam and looking at the same set of labs. For our patient, her history is she had this total knee replacement, and then it was complicated by an infection. She was put on cefepime, then it was narrowed to daptomycin. She was discharged with a PIC. She became febrile, diagnosed with a pneumonia. Then she was put on levofloxacin, and then her whole course was complicated by AFib with RVR. She's had a very bad month, and now until thiazam at discharge, and she's presenting now with this rash. Oftentimes, patients are not straightforward, right? They're not coming in with just one medication and one rash. Most patients have multiple medical problems or are being initiated on multiple medications at one hospitalization. And so in those settings, it's most useful to come up with a drug chart. And when you develop a drug chart, you put out a line, you put in when the rash started, and then I insert all the different medications that are new that somebody's been on. And I would go back as far as about 3 months, and some rashes take a long time to develop. So for this patient, she was started on the cefepime in that setting of that infection. It was narrowed to the daptomycin. Then she was put on the levofloxacin for the pneumonia, and then she was put on metoprolol and diltiazem afterwards. The next question we have to ask in our series on the history and physical exam for the patient is determining mucosal involvement for the patient. And there are 4 sections that we try to ask or concentrate on. The first is mouth pain or ulcerations or difficulty eating. The second question I ask patients about is if they have a gritty sensation in their eyes. And the reason is that pain in the eyes is going to be much more advanced for the patient. It will be something that they present with if they have mucosal involvement farther on in their course. But the first sign is that sort of foreign body sensation that patients can sometimes have in their eyes. And the eye is very sensitive to that foreign body sensation. The next is pain with urination or sexual activity. And the fourth is an abnormal urinary stream. So some patients, especially male patients, they may aim in one direction and notice that they're peeing in another direction because there's been strictures in their urethra. Next, we'll look at this patient's labs, where we notice that her labs are otherwise normal, except for the very mild eosinophil count or percentage, and then no mucosal involvement. She notes no skin pain, and she notes no systemic symptoms other than what she'd had from her pneumonia before. So, based on the information provided, what is the most likely diagnosis? Do we think it is A, SJS, B, acute generalized exanthematous pustulosis or HEP, C, a morbilliform drug eruption, D, drug rash with eosinophilia and systemic symptoms, or E, an atypical beta blocker induced desquamating eruption? And I see here that people are starting to answer. There are some who think that it's more likely to be a morbilliform drug eruption versus DRESS is still on the differential. For some individuals, there's no love for E, atypical beta blocker induced desquamating eruption. A few people who have some concern now about Stevens-Johnson. Maybe we seem like we're sort of settling on answer C, but there's a few people who are concerned about some of these other rashes as well, and we'll get into that as we go through. For this patient, it is indeed a morbilliform drug eruption, and we'll talk about why that is. Morbilliform drug eruption is the name for the general drug eruption, a non-harmful drug eruption that is a type 4 hypersensitivity reaction. That means that patient takes a long time for that rash to develop, usually 7 to 14 days, because the antigen has to be presented, it has to go to the lymph nodes, it has to go back to the skin. So you can imagine that that's a relatively long process. It never has mucosal involvement. As with this patient, there's no mucosal involvement, and very rarely is the patient notes skin pain. It's almost always an itch and then maybe a little bit of pain, as opposed to a primary painful rash. The medication history should be suggestive of a rash. So if a patient comes in and they have been on no medications, they take no medications, they take no over-the-counter medications, then it's very unlikely to be a drug-associated rash. And again, as we discussed, it takes 7 to 14 days for that rash to fully develop. You can see here some examples of what morbilliform rashes can look like. A and B look relatively similar to the patient's in her presentation. You can see here on C that that's a patient who has more of a violaceous rash, and even a little bit of scaling, although that's relatively uncommon. The rash should be without scale. And the thing I most commonly get called about are patients who have something like rash E. Rash E, as you can see here, is a person who has bled into their morbilliform rash, which we see really commonly in patients who have low platelets, who have a very high INR, who have other comorbidities. And so frequently in patients, oncologic patients, perhaps who are undergoing some sort of conditioning chemotherapy and have very, very low counts, they'll bleed into an otherwise normal drug rash. And that can look like vasculitis. It can look like all sorts of very concerning rashes. But generally speaking, it's itchy, not painful. It is very widespread, as opposed to, say, vasculitis, which will generally speaking be on the legs and the buttocks. Vasculitis is completely asymptomatic for most patients. And so you can help to differentiate it in those ways. And if you have a high suspicion because the patient has very low platelets or very high INR, that's when you start to think maybe they're bleeding into an ordinary rash. Based on our patient's history, what do we believe to be the most likely culprit for this morbilliform drug eruption? I'm going to give you some options to think about. Remember that drug chart that we developed for this patient. She was initially put on cefepime, then daptomycin, then levofloxacin, then metoprolol, and then diltiazem. And you can see here that lots of people, as they're answering, are not really sure. Metoprolol seems relatively low on most people's list, but there's still some question as to whether this could be daptomycin, this is cefepime, levofloxacin, or another rash. You can see here, still cefepime seems to be the most popular answer, with about half of people still thinking it's cefepime, another quarter thinking it's daptomycin. No love for metoprolol. The answer in this case is very likely cefepime. We can go back to our handy-dandy drug chart, and that's the most helpful for determining what the underlying cause is. And the reason is about the time frame, right? So we know that these rashes take between 7 and 14 days to develop. And so for this patient, cefepime is by far the most likely thing to have caused it because of that time frame coming in right at around 10 days in terms of exposure. It's also most likely given the kinds of rashes and the kinds of drugs that cause morbilliform drug eruptions. And you can appreciate here that by far and away the most common medications to cause morbilliform drug eruptions are penicillins, cephalosporins, and trimethoprim sulfamethoxazole. Other medications can certainly cause morbilliform drug eruptions, but if we're trying to think about the most common causes, those are almost always the most common causes. And this slide is just to remind you that we're primarily talking about adults here. Adults, when they present with a morbilliform drug eruption, it is almost always from a drug, right? When people present with a morbilliform eruption. In children, the most common cause of a morbilliform eruption is a virus or a bacterial infection. So those of you who have small children will note that children will often present with relatively widespread rashes that are just associated with a virus. And it can be very confusing if the child actually got antibiotics to differentiate between whether that was a viral rash and whether it was from the antibiotics or other medications they received in the setting of that viral or bacterial infection. Teenagers are tricky because they fall somewhere in between, and for the most part, they can either have a rash from an infection or from a medication. The treatment is based on the patient's symptoms. So we generally speaking stop the underlying medication. If a patient can only be on this medication and they're going to be on it for a short or well-defined period of time, say they need to be on this antibiotic because they're resistant to all other antibiotics, the bacteria that they're growing is resistant to all other antibiotics, or they have a lot of other allergies, or for some other reason, and we know it's going to be a very short period of time, you theoretically can treat through the rash, since the rash is not life-threatening, with high-potency topical steroids applied twice daily. Sometimes if patients are really itchy, you can also add prednisone. Obviously, that causes more problems for patients sometimes. So we try to limit it to topical steroids as needed. You continue to monitor for signs of other skin reactions and mucosal involvement with the understanding that a morbilliform rash will never evolve into a more serious rash. A morbilliform rash does not turn into SJS if you keep somebody on the medication. A morbilliform rash is its own thing. It's really the reason to monitor is to ensure that you haven't diagnosed them incorrectly. So you see them, they have no mucosal involvement, you're extremely confident that they have a morbilliform drug eruption. You want to watch them for a few days, ask about symptoms, ask about and keep track of mucosal involvement to ensure that you haven't misdiagnosed or missed the very early stages of Stevens-Johnson's or a more serious drug eruption. We'll move on there to case 2, which is a 27-year-old with no past history who presents to the emergency room with rash, some skin pain, and some chapped lips. And you can see here, this is a photo of the patient, and this is a photo of her back. And I want you to take a little bit of time to write down how you might describe this or what you're paying attention to in this patient's photos. And what I would draw your attention to as you're thinking about this is what's happening to the corners of her mouth. You can see here there's just a little bit of scaling or skin peeling at the very corner of her mouth that does not quite look typical. And you can see that the rash on her back is very violaceous, much more purple. And partly that could be her underlying skin tone, but it looks very diffuse. And then the last thing I would point to is that she also has a little bit of erythema in her cheek. So the rash, a morbilliform rash, is a truncal rash, right? It's a rash that goes from the neck down and very rarely involves the face. But this person has some involvement of their cheeks, which is notable as well. Again, we ask those same questions that we would ask for any patient. We concentrate on their medication history, their infection history, their immunologic status, their systemic symptoms, skin pain, mucosal involvement, and then those basic labs. And then we ask the same screening questions about the patient's potential mucosal involvement. For this patient, the answers are that she's a 27-year-old. She had presented to her primary care doctor for a paronychia, of all things, and 10 days ago had been started on cefalexin or cephalexin and ibuprofen as well as acetaminophen in the setting of that toe pain. 7 days ago, she didn't have any improvement with the cefalexin, so she was initiated on trimethoprim sulfamethoxazole. And 1 day ago, when she noted skin pain, she was initiated on prednisone and the trimethoprim sulfamethoxazole was stopped. She notes some eye itchiness and has a very mild leukocytosis. Based on the information that I have provided to you, and if you were seeing this patient, what would be the most likely diagnosis you think this patient might have? And we'll give you a chance. Again, similar set of answers here. Stevens-Johnson syndrome versus acute generalized exanthematous pustulosis or AGEP, a morbilliform drug eruption, a drug reaction with eosinophilia and systemic symptoms, or an atypical beta blocker-induced desquamating eruption. And we'll give you some time to answer those. By far and away, the most common answer so far is SJS, though there are some people who are worried about DRESS. And then there are a few people who are worried about AGEP as well. Nobody thinks this is a morbilliform drug eruption, which means you're all excellent test takers. We've already covered it, so why would I cover it again? And then no one thinks it's atypical beta blocker induced desquamating eruption, which is not a real thing anyway. It's a thing that I've made up for this questionnaire. Great. So why don't we talk a little bit about, because there's some discussion about whether this is DRESS or whether this is SJS. So we will move forward. This, in fact, is SJS, and we'll talk a little bit about why it is SJS. So I have a concern when I'm seeing this patient for SJS, and the way we diagnose it is based on the following facts: a convincing medication history, and the time frame is really important when you're trying to differentiate, say, DRESS and SJS, right? DRESS, as we'll discuss later, requires a really long time to develop, usually between 3 and 6 weeks from the time of medication exposure, whereas SJS is generally speaking between 5 and 14 days, so it's a much shorter time period in order to develop it. Patients primarily note skin pain, not skin itch, and mucosal involvement is extremely prominent. Almost always. Biopsy can be very helpful in demonstrating that skin necrosis, and so we almost always will biopsy if there's any question at all. Medication is associated with SJS greater than 95% of the time. Essentially, when I can't find a medication and I see somebody who clinically has SJS, I wonder if I'm missing some medication or some over-the-counter medication or some supplement or some other thing like that I have missed that may be mediating their SJS, because it is so commonly associated with SJS. I would also want to draw your attention to the things that we see most frequently in patients. Oral, genital, and ocular mucositis are seen in basically everybody as a disease-defining characteristic. And then patients can also develop systemic symptoms. So patients who have more progressive disease, they have more desquamation, that is to say more skin is dying on them, which is mediating that skin pain. The more likely they are to have 30% or more of their skin involved with TEN, the more likely they are to have systemic symptoms, fevers, to be more critically ill, etc. And then patients can develop respiratory tract epithelial involvement in about 25% patients who have TEN, so have more severe disease. And those are things to watch out for, because that's when you want to escalate care or consider, if you think the TEN is high on the differential, transferring a patient to the ICU or to a tertiary care facility, and we can talk about why and who you would want to get involved in a second. I do want to focus a little bit on the exam. So we saw a patient, the photos that you just saw are of a patient who has a really widespread rash, but SJS-TEN can look a few different ways. So it can be that very, very widespread, extremely flat, confluent rash, or it can be targets, literal targets, as you can see in this person's hands, where the center of each target, or the center of each of those little papules and plaques, is necrosed, and then it can become confluent. So all of those areas, what you see in this picture where the person's skin is dark purple, those are areas that have already necrosed, and the areas that are more violaceous, those are areas that will necrose. We define SJS as being about under 10% body surface area. SJS-TEN is 10 to 30%, and TEN is greater than 30%. One thing to keep in mind is that even for patients who have very limited systemic symptoms or lab findings, they still have quite a high relative morbidity and mortality. So you can see here, there's a score 10 calculation, which helps us predict mortality. Like any of these scoring systems, they're not perfect, but the reason I present it is not so that you can use it to predict mortality, but instead to focus on the fact that even if you are a patient like this patient was, who presented under the age of 40, who has no history of malignancy, who has very limited epidermal detachment, who has normal serum urea and serum glucose and bicarb throughout her entire admission to the hospital, your predicted mortality is still 1%, right? And so that helps to understand why we take this so seriously. Based on what we have presented for this patient, what do you think would be the most common cause of this patient's rash? And here we have a few options. We have Keflex or cephalexin, trimethoprim sulfamethoxazole, acetaminophen, ibuprofen, or an antecedent bacterial infection. And I can see that there's some question as to whether this is Kefalexin that caused this or whether this is the trimethoprim sulfamethoxazole, with overwhelming choice being trimethoprim sulfamethoxazole and nobody really having a high suspicion for the acetaminophen or the ibuprofen or an antecedent bacterial infection. Oh, there's one person who thinks it might be ibuprofen, which is great, and we'll talk a little bit about why that might be. Okay. In this case, the most common cause for this patient's rash is trimethoprim sulfamethoxazole. That doesn't mean these other ones aren't possible. It just means that the most common cause in all comers for SJS is trimethoprim sulfamethoxazole. For this patient, given the time frame, actually Kefalexin, trimethoprim sulfamethoxazole, and ibuprofen are all potential causes that could mediate this patient's SJS. That doesn't mean they are the causes, but they all could potentially be the cause, with trimethoprim sulfamethoxazole being the most likely. And you can see that here in the data, where when we think about all comers for SJS-TEN, there's lots of different bacteria antibiotics that are listed on there, but the most common by far is a quarter of people have SJS from trimethoprim sulfamethoxazole. A quarter of people present because of antiepileptics or mood stabilizers, with about 12.4% for a beta-lactam antibiotic, and then a little bit less than that, a little bit less than 10% for allopurinol. Those are the key players. So it's not just a list of antibiotics, but instead very specific antibiotics and then very specific other medications as well. Based on the morbidity that patients experience with SJS-TEN, who should be consulted the earliest for this condition? And here we should have audience questions, but I don't know if there'll be an interaction portion here. Great. And the different options for who you should consult earliest are between ophthalmology and dermatology right now, and not many other consultations so far. Dermatology is winning out right now, though there's still some people who are considering calling ophthalmology, a few people who are thinking about OB-GYN or oral medicine, and urology, somewhat limited. So really we're concentrating primarily on ophthalmology and dermatology. And I think it's very reasonable to call both, and actually you're going to end up calling all three. But based on the morbidity that patients experience from SJS-TEN, the person you should consult most quickly is ophthalmology. And that's borne out in some of the data. This is from the British Journal of Dermatology, and you can see here that the most common chronic manifestations of Stevens-Johnson syndrome are actually primarily ocular. And ophthalmologists, when they come in and evaluate patients, can put in special lenses and other medications to ensure and protect the cornea so that patients don't have chronic problems with their eyes and eyesight in the setting of SJS-TEN. Honestly, the most common thing that patients have, other than ocular and skin and other issues with SJS, is psychological issues after SJS-TEN. Many patients have significant depression, PTSD, and anxiety afterwards, especially when confronting other medications. Management of SJS-TEN requires a whole team approach. You stop the causative medication. Supportive care is critical with petroleum jelly, with zero form, which is that sort of like various kinds of mesh and gauze products. You don't want to break those blisters. You want to let the blisters stay on as a biologic dressing. Mouth care with lidocaine mouthwash, topical steroids to the mouth, and dexamethasone washes. Topical, high-potency topical steroids, and then you're consulting a lot of people. Dermatology, obviously, if there's high concern, ophtho for corneal protection, OBGYN, because they can place dilators into the vaginal canal to prevent the vaginal canal from scarring closed, Foley placement for men, and then burn and or ICU level care to manage insensible losses and wound management, depending on how severe and widespread the patient's SJS-TEN is. So if the patient's SJS-TEN is a significant body surface area desquamation, they need a high level of nursing care that will likely require ICU level care and potentially burns. You wouldn't go wrong if you have a high suspicion for SJS-TEN to consider some sort of therapy while you're waiting. And usually the safest and easiest thing and least controversial is IV methylprednisolone. Cyclosporin, IVIG, and etanercept are used at various other institutions across the country to treat SJS/TN, but it's very hard to conduct good randomized clinical trials of the treatment of SJS/TN, and so we do not yet have a definitive winner amongst these treatment options, though it can often be institution and dermatology department dependent. With ideal management, fast recognition in this healthy patient, right, this 27-year-old with no past medical history, no other medical problems, it is still a pretty significant condition. So this patient had the ideal care. She presented to a hospital that had a dermatologist and ophthalmologist readily available. She presented within 7 days of what we suspect to have been the inciting medication. It was stopped pretty closely, and this is her mouth, and then this is her after, and you can see there's really significant desquamation across her lips and in her tongue. And then eventually she had this very superficial desquamation, and she healed up great and did very well. And she was actually managed entirely on the floor and without needing any ICU level transfer, but I think a lot of that had to do with the fact that she was otherwise healthy. Case 3 we'll move on to now is a 64-year-old with a history of bullous pemphigoid, status post-rituximab, and with fevers daily, and now a rash. I want you to take about 30 seconds to write down a description of this rash, maybe 15 seconds, and sort of look at this features for a moment to think about what we're seeing. You can see here that the patient seems to have some rash involvement of her face. She has a rash around her neck, and then you can see it's quite confluent. There are areas that look almost violaceous or purple around here that look more dusky. There's areas that are probably non-blanching, so this area here where it looks like the skin has peeled off a little bit. And it's hard to tell if there's any mucosal involvement. We can't really tell, but there does appear to be very prominent facial involvement and some scattered papules. Again, we always ask the same questions. We are monitoring for the same symptom, signs, history, and exam, as well as the same labs for every person. So for this patient, she's a 64-year-old with a history of bullous pemphigoid, status post-rituximab, which really speaks to her immunologic status. And she got prednisone at that same time, around 3 months ago. She has newly diagnosed gout, and she was initiated on NSAIDs and colchicine. And then following acute resolution about 6 weeks ago, she was initiated on allopurinol for her elevated uric acid level. And then beginning 2 weeks ago, developed fevers daily and this new rash. When you obtain her labs, her creatinine is 4 from her baseline of 1. Her liver function tests are normal. Her absolute eosinophil count is around 3,000, and she does have atypical lymphocytes present on her smear. Based on the information provided, what is the most likely diagnosis? So our options here are Stevens-Johnson syndrome, acute generalized exanthematous pustulosis, morbilliform drug eruption, drug rash with eosinophilia and systemic symptoms, and an infectious process. And DRESS is right now the only answer people are giving, which is great. See if we'll give everybody a little bit more time. Some people wonder if this may be age up. But the super majority of participants think this is DRESS, with a few people wondering if this is a standard morbilliform drug eruption. Great. So for this patient, while DRESS is the most likely in the setting of this presentation where I'm talking about dermatologic emergencies, an infections process has to be ruled out. This is a patient who's been given rituximab. She has an abnormal immune system at this point. Immunologic status is not normal. She's not able to mount the same kind of responses we might ordinarily expect, so she may be at risk for various infectious diseases. Any rash that occurs on the face primarily and then moves down has to also make us think about other processes. It's when we start to think about measles or mumps, because both of those rashes, or rubella, measles or rubella, sorry, because both of those rashes can present, both of those conditions can present with rashes on the face and then move down. And in patients who have a more atypical immune status, they may be at higher risk for those conditions, or patients who are unvaccinated. So the key with any of these conditions is to rule out an infectious process first. In this case, it is DRESS. Obviously, I'm talking about significant drug rashes today. But DRESS often requires that we rule out those infectious processes, as you'll see. DRESS is a drug rash that requires 3 to 6 weeks to develop, and that's because of the underlying pathophysiology of drug rash, of DRESS. It can develop with any rash morphologically, and we'll talk about and show a bunch of different examples. So it can look like a morbilliform rash. It can look like a rash that's desquamating with like SJS-TEN. Instead of thinking about DRESS as primarily a dermatologic condition, it's not really. What it is a very acute inflammatory process. And so patients present with a rash. The rash is only one piece of the puzzle. The other things that we think about and that patients frequently present with are signs of systemic severe inflammation, including fevers, facial edema, lymphadenopathy, arthralgias, and arthritis, all of which are really common. And of course, end organ dysfunction, and any organ can be involved. So in this patient, we didn't see the typical LFT elevations that we might see with somebody with DRESS. We saw an elevated creatinine, which is a very common thing that you'll see. But any organ system can be involved. So we'll see primarily CBC abnormalities. So patients can have atypical lymphocytes on their smear and eosinophilia, nephritis or elevated or dysfunctional kidneys, elevated liver enzymes, troponin elevations, thyroid elevations or thyroiditis. And then there's a very common thing that we'll see in patients where they have reactivation of these herpes varidae infections, these pediatric herpes varidae infections, so HHV 6 and 7, roseola infections that are reactivated for reasons that are poorly understood. Here are some examples of what this rash can look like. It is varied across populations, but you can see that the rash is not very specific. So the patient up in the middle looks almost like they have an urticarial eruption. The patient in the upper left-hand corner looks like they have a confluent morbilliform eruption. The person in the lower corner looks almost like they have an eczematous or more violaceous rash. And then we have our patient here who has more of what appears to be a desquamating rash that you might see with SJS-TN, but is not. There are various scoring systems for diagnosing DRESS, and you can see here that they primarily involve that systemic inflammation, right? Lymphadenopathy, circulating atypical lymphocytes, peripheral eosinophilia, and fevers. Skin involvement is only one part of the diagnosis, right? Internal organ involvement is really critical. And then, as we alluded to, you have to rule out these other infections and or inflammatory processes, getting an ANA, blood cultures, hepatitis, A, B, C, serologies, chlamydia, and mycoplasma serologies as well. And you can see here again that focus on the various lab abnormalities that can be seen in these two scoring systems. There's a Japanese and an American one, the registrar and the JSCRAR. I don't want you to concentrate on all these different drugs that can cause DRESS. The most common are these medications that have a very specific arene ring that's required in order to develop DRESS. DRESS requires a specific drug and likely a specific HLA type. So there's specific HLA types in combination with specific drugs that are much more likely to cause DRESS, so much so that for certain medications like carbamazepine in certain populations with a very highly prevalent HLA type, they will frequently test that HLA type before they will start carbamazepine. But the most common drugs are allopurinol, anti-epileptics like carbamazepine, lamotrigine, and phenobarbital, and sulfasalazine. And you can see here that time course that we emphasize. It takes a long time for a DRESS to develop. So in this patient, they put on allopurinol and then they developed it. So for this patient, we now think that they probably have DRESS. It's probably from allopurinol. We have stopped the allopurinol. What is the next step in terms of our treatment? Should we do supportive care, a low dose of prednisone at 0.25 mg per kg for 7 days, high dose prednisone 1 milligram per kilogram for 2 to 4 weeks, and a slow taper, IV acyclovir for 7 days, or ibuprofen standing? You can see a lot of people here saying maybe supportive care is what's necessary, but most participants are about 2/3 still feel that a high dose of prednisone is going to be the most beneficial for this patient. There are a few people here who are advocating for the low dose prednisone as well. We'll see if there are any other responses. Nobody wants IV acyclovir, it looks like, even though there is that viral reactivation of herpes varidae infections for a lot of patients. Oh, one person has taken a cue and decided to answer that one. That's great. So the answer is a high dose prednisone, and we'll talk a little bit about why that is. So it is possible to walk away from DRESS without being put on prednisone, but it is relatively unlikely. And the idea is that if a patient has non-severe DRESS, and that's defined here below essentially as having no signs of end organ dysfunction of any kind, then you can do daily clinical monitoring and laboratory functions every 48 hours to make sure that they're doing okay. If they have severe DRESS, which is how almost every single person I've ever seen with DRESS is presented, they're presenting with some sort of abnormal lab functions that meet these criteria, and then they get put on 1 mg per kg of prednisolone per day for 2 to 3 weeks with a very gradual taper. And the reason for that is because if you taper too quickly, patients can have recurrence of their DRESS. In addition to that, you can consider other treatments if either patients continue to progress or they have a contraindication, so cyclosporin or IVIG or plasmapheresis. But the bottom line is, if you have a high suspicion for DRESS and the patient has signs of end organ dysfunction, then initiating 1 milligram per kilogram of prednisolone is recommended. And then the patient needs to have long follow-up for these for every organ that could be involved in SJST. And as you can see here, patients can have a significant and intractable heart failure. They could have ARDS. DRESS is really no joke. We're going to take the last few minutes. We have some time for questions to talk about one final rash. She's a 64-year-old. She has a history of SJS previously, and she presents with a new rash and fever. So this is her rash. You can take a few seconds to describe the rash. And the things I would focus on here are the pustules on this sort of red or pink base all across her body. This is almost what we would describe as lakes of pus all across her body. So peripheral history, again, we always ask the same questions. Is a 64-year-old with a history of Stevens-Johnson's previously, and she's presenting with this new rash and fevers. 14 days prior to developing the rash, she was started on doxycycline for a Lyme infection, and then she developed atrial fibrillation with RVR and was initiated on diltiazem 5 days prior to the rash and fevers. You can see this is her drug chart here. So what do we think the most likely diagnosis is for this patient based on her clinical presentation and the medications that she was exposed to? So one possibility is Stevens-Johnson syndrome, acute generalized exanthematous pustulosis or AGEP, generalized impetigo, given all those pustules, a morbilliform drug eruption or drug rash with eosinophilia or DRESS. Again, some excellent test takers here who've seen that we've talked about almost all of these other rashes. No one's going for the generalized impetigo. 1 or 2 people are, but most people think that this is AGEP. Some people are wondering if this could be DRESS, maybe because of the fevers that the patient has had when they presented with this rash. And the answer here is actually AGEP. We'll talk a little bit about it. So some key features of AGEP here are that you can see these lakes of pus, this erythematous base, and then you can see here some very superficial desquamation. The neutrophils in this condition go right underneath a very superficial layer of the stratum corneum, and so can appear as the patient is progressing that their skin is peeling. Their skin is peeling, but very superficially, and it is often misdiagnosed as SJS. So for this patient who I met in the hospital and carried a diagnosis of SJS previously, she very likely actually had a history of AGEP previously. That was my guess. And you can see here it can look different in different skin types, more violaceous base, but with those numerous pustules, or it can be very subtle. You're really looking for these very, very small pustules in this case that are coming together as these confluent lakes. AGEP is a weird condition. It is an acute rash. It is 90% of the time associated with medications and very rarely associated with viral infections. It occurs quickly. So the patient gets the medication, and within a 2 to 5 day window of exposure to that medication, they develop AGEP. It is generally quite inflammatory, right? It's a big marginalization and movement and mobilization of neutrophils to the skin. And so patients develop all of what you might expect from really high neutrophils. And so that includes some fevers and feeling quite poorly, but it generally is a rash that can self-resolve. When I see patients in the hospital who've developed AGEP, often they require some sort of systemic treatment like prednisone or cyclosporin. The common drugs that cause HIP are also really unusual. So I would focus our attention on the fact it's one of the few rashes that is caused by cardiac medications, specifically calcium channel blockers like diltiazem, antimalarials, isoniazid, and then some of the chronic players like antibiotics and antiepileptics. This is a nice chart that just sort of outlines the telltale signs as you're sort of thinking through whether somebody may have SJS, TN versus morbilliform rash. Always asking about mucosal involvement. DRESS will almost always have some sort of systemic involvement, that lymphadenopathy, facial swelling, fevers, and then HIP will have those pustules. And then if you're seeing them very late, that very superficial skin peeling and fevers. But if they don't manifest any of these other symptoms, then it's very likely a nice, boring morbilliform drug eruption. With that, I'm happy to take some questions if there are any.
Perfect. That was awesome. Yes, we do actually have a few questions from the audience. This question is super interesting. So you did a really good job, kind of even changing the way that I think about asking about like mucosal involvement, right? Talking about urinary streams and eye like burning and itching. Are there ways, like what are the different ways you hear patients describe skin pain other than just tenderness? And the question includes like, is it like itching, burning? Like what are things that maybe we wouldn't pick up on?
That's a great question. I think that's probably the least sensitive because when people have been scratching for a long time, their skin starts to hurt. So even a morbilliform eruption can start to hurt if somebody's bleeding into their rash. So those patients that we showed pictures of before, that will also hurt a little bit more. So it's probably the least sensitive. But most people feel when they describe SJST and it starts off before it peels and it feels horrible, like a sunburn, right? It feels like, the skin is dying. So it feels like a burning sensation, much more than an itch. The itch is really, really almost non-existent as opposed to feeling like a fold. So that patient, she presented very, very early that I showed a picture of, and she described, she's like, I just kind of feel like I have a sunburn and I've never had a sunburn before. So that's the most common.
In patients with DRESS from a medication like allopurinol, are there lists of medications with similar like chemical characteristics that we should be, maybe if we don't have it memorized, we should be looking that up, right? When patients discharge to put it into their allergy chart.
So we don't know. We don't yet, though there are people who are developing this, have tests that can be like, this is the thing that caused your rash, or this is the thing that will cause your rash. Generally speaking, it's like a 1-to-1, like the drug and the HLA type together. So allopurinol and this person are not going to agree with each other, but that doesn't mean that they're going to develop DRESS to carbamazepine, even though they can share some of those similar features. Carbamazepine in very specific populations, very high level of DRESS. And then there's some specific HIV medications that so commonly were associated with DRESS and other things like that, that people's HLA type is tested before they're started on it.
Okay. Sorry, keep going.
There is a grant that one of the researchers at the Brigham just won to look more specifically at tests that we would be able to practically use. I think that's in the pipeline, but not yet available. So that somebody who has a history of SJS or DRESS, one of these very severe drug rashes, would be able to come in with a bunch of medications that they were started on, and we'd be able to figure out which one caused it. But we don't have that right now.
Okay, we'll stay tuned for that for sure. You had mentioned some topical steroids in some applications, and one of the participants is asking about different steroid types, different topical steroid types for different parts of the body. And do you have any kind of like broadly speaking, how we think about that?
Totally. I think it's helpful for everybody to have 3 topical steroids that they have in the back of their mind and not have to think about anything else that's too complicated. So you should have one class 1 topical steroid that is covered by insurance in your area. And this, which is unfortunately, so used to be betamethasone augmented here, and now it's clobetasol or halobetasol. Those are all class 1s. Then triamcinolone's in the middle. Clobetasol, you can put like anywhere below the waist except the groin and the armpits. And then triamcinolone is in the middle, and it's like good if you need to cover a huge area, body surface area, because
Okay.
it comes in a tub and it's always covered. And then you need a weak topical steroid. So it could be like hydrocortisone 2.5% or hydrocortisone valerate or one of these other ones. And just pick the one that you think is going to get covered by insurance most frequently, especially for outpatient physicians. And that's the one that somebody can use on their face. 7 days for the face, 14 days for the rest of the body. But, if
Okay.
somebody's skin is falling off, like, you can go crazy. It's okay. Like, I'm much less worried about skin atrophy in patients who have SGS, like, it's okay.
Yeah. Lather it on there, right?
Yeah.
And then I think our last question is, you talked about this a little bit, but when you were mentioning like switching to sending patients to a tertiary care center or an ICU, is there any time where you just look at a patient and you're like, this person needs to be specifically in a like a burn center or a burn ICU?
Yeah. So the general rules, if somebody has greater than 30% desquamation of their skin, they should almost certainly be in an ICU. And sometimes nurses will drive that too, because it's not about the medical care as much as it is about the nursing care, right? And how significant the nursing care is required to keep people from getting an infection when they have such significant desquamation. And then tertiary care would be if you need somebody to be if you need consults for dermatology, ophthalmology, OBGYN, and they're not available at your institution, then the person has to go.
Very helpful. Yeah. Okay, Dr. Charrow, thank you so much.
Thank you. It was great. I really appreciate it.